All right, we are jumping straight into something absolutely fascinating today. We're taking a ride along with a neuropathologist to really demystify one of the most intense, complex events the human body can endure, a traumatic brain injury, or TBI. We're going to track exactly what happens to the brain from the literal millisecond of an impact, all the way through to the aftermath years down the line. We're talking a massive journey from physics to biology and ultimately to psychology.
Here is our diagnostic roadmap for the phases of a TBI. Section 1 covers the physics of mechanical deformation. Section 2 is grading severity with the GCS. Section 3 pits focal versus diffuse brain injury. Section 4 explores navigating the metabolic cascade. And finally, Section 5 looks at chronic behavioral outcomes. This is going to guide us seamlessly from the macroscopic physics of a hit down to the microscopic biology and out to long-term psychology.
Section 1. Physics of mechanical deformation, the invisible forces inside the skull. So we've got to begin at the exact moment of trauma, right? To a neuropathologist, every TBI essentially starts with mechanical deformation of the brain's functional tissue, the parenchyma. But the brain isn't just taking one single type of hit. It's really crucial to contrast the forces at play here, linear acceleration versus rotational acceleration. Think of linear forces as a straight, direct push. You take a direct hit, front to back, and the brain is propelled along those specific forced vectors, literally dragging across the rough, bony ridges at the base of the skull. Yikes. Rotational acceleration, though, that's entirely different. Because your brain is tethered at the bottom by the brainstem, a sudden twisting motion causes it to rotate around that axis. Imagine violently twisting a thick bundle of cables. That rotational force literally shears the brain's white matter apart. And that brings us to the classic linear coup-contra-coup impact pattern. Picture this. A person takes a harsh hit to the front of the head. The brain actually accelerates forward inside the skull, smashing into the bone at the front. That is your coup injury. But then it rebounds. It flies in the opposite direction and strikes the back of the skull, creating a secondary contra-coup injury. It's essentially a localized double impact, and it very often leaves severe contusions right on the frontal poles and the anterior tips of the temporal lobes. Section 2. Grading severity with the GCS, measuring altered consciousness. Transitioning from the harsh physics of an impact right into the emergency room, clinicians face a really massive challenge. The brain is enclosed in bone. They can't just look and see the physical tearing. That is exactly where the Glasgow Coma Scale, or GCS, comes in. Clinicians use the GCS to assess 3 specific behavioral responses to quickly gauge what's happening with brain function. First, they check eye opening, like can the patient open their eyes spontaneously or maybe only to pain? Then they check the best motor response. Can they obey physical commands or do they just withdraw from a painful stimulus? And finally, verbal response. Are they oriented or totally confused and incomprehensible? Basically, the higher the score, the more intact the brain's baseline function is. Let's break down the exact clinical criteria that separate mild, moderate, and severe injuries. A mild TBI, which is what we usually just call a concussion, sits at a GCS score of 13 to 15, usually with a very brief loss of consciousness if they lose it at all, less than 15 minutes. But as that score drops, say, down to a GCS between 3 and 8, we are suddenly in the severe category. Here, you're looking at a prolonged loss of consciousness spanning up to 48 hours and post-traumatic amnesia that can last for up to a whole week. The GCS gives medical teams the critical, standardized language they absolutely need to determine treatment and prognosis immediately. Section 3. Focal versus diffuse brain injury, structural damage versus cellular disruption. Once a patient is stabilized, we have to look holistically at 2 entirely different yet simultaneous patterns of injury across the spectrum. We've got localized structural bruises and widespread cellular tearing. Let's look at how a focal injury progresses. A direct cortical bruise from that coup-contra-coup impact we talked about. It triggers a really relentless path of structural decay. First, you get local hemorrhage. That bleeding can actually pool and eventually organize into chronic subdural membranes, creating this lasting physical pressure on the brain. That restricted blood flow leads to ischemia and swelling, also known as edema. Now, deprived of oxygen, the tissue literally dies, a process called necrosis. And finally, that dead brain tissue is cleared away, leaving behind empty cavities and scars in a process known as cavitation and gliosis. It is literally a localized structural collapse. Now contrast that localized collapse with disuse axonal injury, or DAI. Remember those rotational twisting forces we mentioned earlier? Well, that twisting doesn't just bruise one specific spot. It severely shears neural processes and blood vessels all throughout the white matter. And this leads to an incredible, frankly bizarre phenomenon called Wallerian degeneration. The physical force actually tears the axon right away from its neuron cell body. That severed axon then degenerates and dies off, completely destroying the brain's communication network. But here's the wild part. The main neuron cell body amazingly remains alive. It's just completely disconnected. Which inevitably leads us to a massive question. The physical tearing has stopped, the patient is in the hospital, but what actually happens at the cellular level in the hours and days after the physical impact? Let's find out in Section 4, Navigating the Metabolic Cascade, the Secondary Injury Phase. So we are shifting our focus entirely away from the macroscopic physical tearing, down into microscopic biological chaos. Because the truth is, the initial physical hit was only the catalyst. Minutes, hours, and even days after the impact, the brain goes into a deep cellular shock. Damaged cells start releasing highly toxic levels of glutamate. You get this massive influx of calcium flooding into the cells, which triggers severe mitochondrial dysfunction. The brain is trying desperately to restore balance, but in doing so, it creates an intense energy deficit. Essentially, the brain's own molecular recovery attempt spirals completely out of control. It creates a secondary brain injury through oxidative stress and massive inflammation that can drag on for days or even weeks. And finally, Section 5, Chronic Behavioral and Structural Outcomes, the long-term aftermath. As we zoom out to the end of injury, we have to look at how an acute injury, that initial mechanical deformation, plus the toxic metabolic cascade that followed, actually transitions into long-term chronic consequences. Sometimes this happens years or even decades down the line. When neuropathologists compare a normal brain to one suffering from chronic traumatic encephalopathy, or CTE, it's pretty staggering. You can see how historical mechanical deformation evolves into widespread pathology. All that constant inflammation, the sheared axons, the completely disrupted protein degradation, it all culminates in these irregular distributions of toxic tau proteins, clumping up in the superficial cortical layers. You even see the physical dilation of the brain's ventricles. The entire structure of the brain has been permanently changed. And here is the ultimate kicker. Because structure dictates function, this physical degradation directly causes chronic behavioral symptoms. All those physical hits to the frontal and temporal lobes, the widespread shearing of the communication white matter, that relentless long-term neuroinflammation, it all fundamentally rewires a patient's psychiatric behavior. We're talking about a severe loss of emotional impulse control, chronic anxiety, deep depression, and major executive functioning problems. The physical physics problem we started with has morphed into a permanent psychological reality. We've traveled from the harsh, immediate physics of a sudden impact through the slow, relentless biological cascade, arriving finally at the profound behavioral changes that can alter a human life forever. So I'll leave you with this to ponder. If a single mechanical impact can invisibly rewrite our brain's metabolic and behavioral future, how must we rethink the way we protect our minds today? Thanks for coming along on this ride-along to explore the incredible complexity of traumatic brain injuries. Keep asking questions and keep learning.